everyone. I'm going to be talking on elbow instability this morning. This is what we're going to be covering, so a bit of anatomy, different types of dislocations and instability patterns, as well as chronic unreduced dislocations. In terms of the anatomy, there's a number of static and dynamic stabilizers. The main static stabilizer is the actual ulnohumeral joint and its congruency itself. However, the radiocapitellar joint does provide some stability as well. Then there's the strong ligamentous structures on each side, the medial collateral ligament and the lateral collateral ligament complex. And the capsule also provides some stability. The brachialis biceps and triceps muscles act to compress across the joint and assist with varus and valgus stability as well. And the common extensor origin muscles provide varus stability, while the common flexors provide valgus stability. In terms of the ligaments, the medial collateral ligament complex is on the left, which is more important than the lateral collateral ligament complex, as the carrying angle biases the loading towards a valgus force on the on the elbow. The anterior bundle is marked there AB, is the strongest part of the ulnar collateral ligament or medial collateral ligament, and is a primary restraint to valgus force in all positions except full extension, while the posterior bundle is the primary restraint to valgus force in extension. There is a transverse bundle there as well. It provides minimal contribution to stability, it's thought, but it does connect the anterior and posterior bundles together, and the MCL is taut in pronation. In terms of the lateral collateral ligament complex on the right, the lateral ulnar collateral ligament, which is the LUCAL, and that goes from the lateral epicondyle to the posterior to the radial head, sort of buttresses it from behind and attaches to the supinator crest of the ulna, and it's a primary restraint to posterolateral rotatory forces. The radial collateral ligament, RCL, goes from the lateral collateral to the annular ligament and also the supinator muscle, and then the annular ligament, it goes from the anterior and posterior margins of the radial notch of the ulna, and sort of encompasses the radial head. There is an accessory lateral collateral ligament you can just see distal to the annular ligament, which also provides a small amount of stability. And the LCL is taut in supination. In terms of the types of dislocations, they're described based on the direction of the dislocated ulna, of which the posterolateral dislocation is the most common. Simple dislocations whereby there are no fractures account for 50 to 60% and are usually stable on relocation. Complex fractures are ones where complex dislocations are ones where there are fractures as well, and most commonly occur between 15 degrees of, or technically hyperextension, and 30 degrees of flexion, where the MCL is at its least or lowest effectiveness. Axial loads, when patients fall on an outstretched hand, lead to stress on the anterior coronoid, which can lead to fractures. And the more flexion you have at the time of the injury means a larger coronoid fragment. However, if you do actually load the elbow in more than 30 degrees of flexion, patients are much more likely to get an olecranon fracture rather than a coronoid fracture. In terms of the mechanism, this is a fallen and outstretched hand, which is partially flexed and with a pronated forearm. As the hand is placed on the ground and it is immobile, the humerus internally rotates on the fixed forearm, and that provides a relative external rotation force on the elbow, which then leads the ulnar and radius to rotate and displace posterolaterally in the majority of circumstances on the distal humerus. There is some evidence to say that the lateral collateral ligament complex is ruptured in nearly up to 100% of elbow dislocations, while the common extensor origin can be avulsed in up to 66 or 2/3, and then the anterior bundle of the MCL, which can be injured in almost half of elbow dislocations. So in terms of examination, you want to make sure you confirm that it's a closed injury, not an open injury, that there's no evidence of compartment syndrome. The most common neuropraxias we see are ulnar nerve and anterior interosseous nerve neuropraxias. And then you want to make sure that you're ruling out other associated injuries. So it's not uncommon, or it's relatively uncommon, to see an Essex-Lopresti injury whereby we get a distal radial ulnar joint dislocation and interosseous membrane injury with a elbow dislocation. So you just have to rule that out because that's a significant injury that needs specific management. In terms of the goals of treatment, we want a stable and functional elbow. The majority of things, ADLs, can be done within a 30 degree to 130 degree arc of flexion and extension and a 50-50 degree arc of pronation supination. In terms of the management of simple dislocations, it's important that these are reduced in the emergency department, and the examination while the patient is under some kind of anaesthetic is invaluable if available. So if an orthopaedic registrar is able to reduce this, knowing the stable range of extension that the patient can go to helps guide the range of motion at the 1 week review when the patient comes out of their immobilization to allow for early range of motion. It's important to examine for medial and lateral bruising and tenderness, as lateral bruising generally indicates a higher grade injury due to the rupture of the strong lateral fascia. In terms of MRI, it's quite controversial and it can lead to over-treating if used as a guide in management in isolation. So there is this study by Robinson, who's an orthopaedic surgeon who uses MRI for all patients that have simple dislocations, and he considers examination under anaesthetic if it wasn't done at the initial relocation if the MRI shows a high-grade injury. And then if there's any evidence on EUA of anything more than mild instability, he proceeds to stabilise the elbow, and I'll show you a picture of that shortly. Considering this, though, in the overall scheme of things, only or less than 10% of patients that have simple dislocations will end up having surgery, and this is often due to chronic instability. In terms of instability patterns, one way to understand the different types of instability is to consider the columns of the elbow. And so we'll be mainly dealing with the medial and lateral column, which relate to the strong ligamentous structures on either side, but there are also injuries that involve the anterior and posterior columns. So in terms of valgus instability patterns, these are the ones that we're going to be going through. So we're going to start with the pure valgus instability pattern, which is an MCL injury. So the pure valgus instability is commonly seen in overhead throwers, whereby there's a repetitive valgus stress on the elbow, which leads to a distractive failure of the medial collateral ligament from microtrauma and causes its incompetence. In terms of how patients present, they generally have reduced throwing velocity and accuracy and pain over the medial aspect. This is commonly associated with ulnar nerve symptoms, so that needs to be examined as well as at the time of the operation. If the patient's going to have a reconstruction, then it's important to consider an ulnar nerve neurolysis. The test to determine whether this is MCL instability are that of the Jobs and Milker test. So the Jobs test is shown in the top right there, where the elbow is in approximately 25 degrees of flexion just to unlock it, and then a gentle valgus stress is applied with the forearm in pronation. While the Milker test is in the bottom right, which involves shoulder external rotation with a supinated forearm, and the elbow is extended while applying a valgus force by pulling on the thumb. There is some evidence for non-operative management of these patients with physiotherapy to balance the common flexors and common extensors, as well as the ulnar and radial deviators of the forearm and wrist. However, only approximately 50% of patients are able to return to sport over a 6-month period. So the surgery that is described to reconstruct the incompetent ligament is the Tommy John surgery, which was named after the baseball pitcher who was the first individual to have the surgery. And I'll describe that surgery in just a second, but this is, as I was mentioning before, the EUA for patients. So this is the EUA for a pure valgus instability. You can see gapping on the medial side with a valgus stress that's been applied. So anything greater than 3 millimeters is positive, and the patient should proceed to MCL reconstruction. In terms of the surgery, this is just some pictures describing it. So the top 3 pictures relate to an acute repair, which is often not possible in these patients because it's usually a chronic condition, which means the tissue is poor quality and the acute repairs fail. However, if it's an acutely avulsed MCL in a patient that's had an isolated injury where they've felt the elbow go pop, then this is a possible repair strategy or possible management strategy for patients through a transosseous tunnel. And this also shows an ulnar nerve neurolysis with it's been transposed using a fascial sling from the common flexors. The bottom images depict the Tommy John surgery, where it's usually performed with either a palmaris longus or a gracilis graft, and there's a humeral Y-shaped tunnel that's drilled, which overlies the medial epicondyle, and then an ulnar AP tunnel or anterior to posterior tunnel, which it's orientated at the level of the coronoid tubercle. For these patients, there's good evidence to say that a much higher proportion of them return to their previous level of sport. so up to 83% in this study. However, they're not able to do any throwing for 6 months and no sport-specific stuff for 12 months. In terms of the next one we're going to move on to is valgus and axial load, which leads to radial head fractures. So this is describing a pure valgus stress with an axial load without dislocation. And so this can lead to instability as we mentioned before, the radial head and the radiocapitellar joint plays an important role as a secondary stabilizer. And so the radial head should be surgically fixed or replaced in circumstances where non-operative management may lead to valgus instability. Now this is going to be the crux of the talk. This is the valgus with the axial load and the external rotation force, which was the mechanism described earlier, which can lead to posterolateral rotary instability. So this is a depiction of the different stages of posterolateral rotatory instability and the injury that occurs. This spectrum of injury relates, or the words in this injury relate to the coronal forces placed on the elbow, so valgus force, and then the rotatory forces placed on the elbow at the time of the injury, so posterolateral rotatory forces. It's a spectrum of disease and occurs in a predictable pattern of soft tissue injury, and this is known as the Horizon circle, which is described or is depicted on the right-hand side, which helps to classify the condition into different stages. So the stage 1, the PLRI, is where the lucal and or plus or minus the radial collateral ligament is injured, where it usually avulses off the lateral epicondyle, and this is usually reducible. Patients will have valgus stability on testing and often feel recurrent snapping sensations in the elbow. The second stage there, which is perched, is where there's additional tears of the posterior and anterior capsule, which you can see on the right-hand side. This increases the instability, leading to an incomplete dislocation, and patients in this stage will have varus and valgus instability as well. And then stage 3 is where the elbow completely dislocates, whereby there's an injury to the medial ulnar collateral ligament, and that's obviously a much more high-grade injury. The causes of PLRI is anything, or can include anything that makes the lateral collateral ligament complex incompetent. So trauma is the most common cause. However, after a supracondylar malunion in the patient that has cubitus varus, this can cause incompetence of the lateral collateral ligament. Then you've got connective tissue disorders such as Ehlers-Danlos, coronoid dysplasia, and even iatrogenic causes such as an overzealous debridement or multiple debridements of a common extensor origin, or a prior Cocker approach for radial head ORIF. So this is a video that's going to just depict the injury pattern or the mechanism in PLRI. And these injuries can often lead to fractures as well, which we'll discuss later, including the terrible Triad type of injury. In terms of the presentation, patients will often have lateral elbow pain, a sensation of clicking, clunking, and even a bump or a dimple over the radial head, which indicates the radial head is subluxating and drawing the posterolateral capsule into the radiocapitellar joint. I'll show you that shortly. There's been a number of functional provocative tests that have been described, which include the push-up, tabletop, and chair tests. These all simulate a combined valgus, axial compression, and supination force on the elbow to try to produce symptoms. The Driscoll pivot shift test is a test that's been described before, however, it has low sensitivity while the patient is awake. So I'll actually describe the posterolateral rotatory draw test, which is a much more sensitive test in the awake patient. The O'Driscoll test does have 100% sensitivity when the patient's anaesthetized. I'll go through the posterolateral rotatory draw test shortly. So this is a video of that test, and it's got some description with it as well.
It is performed with the patient in the supine position in the arm overhead. The forearm is held securely in neutral rotation between the examiner's arm and upper body. A posterolateral force is then applied to the radius. If needed, a gentle valgus torque can be added to accentuate the instability. Note the clear subluxation of the radial head here.
This is the dimple right here that gets sucked in behind the radial head. Here's the radial head and the olecranon. Here's the dimple, and you watch this as a posterolateral rotatory subluxation, right like that. And it's dependent on the flexion in.
So that's just depicting a patient obviously awake. So it's a test that can be relatively easily performed in the clinic with a patient relatively comfortable. In terms of imaging for this injury in the initial stages, there there is a characteristic MRI lesion called the Osborne collateral lesion, which is a lesion on the posterolateral capitellum, which is depicted here by the yellow asterisk. The orange arrow in this circumstance on the left-hand side is pointing to a lateral ulnar collateral ligament tear, while the red arrow is the widening of the radiocapitellar joint, and the green arrow represents the radial collateral ligament, which has also been torn. In this circumstance, there's been an injury to the ulnar collateral ligament, which is indicated with the blue arrow. As mentioned before, the PLRI can present anywhere along the spectrum, and patients may or may not have had a traumatic dislocation. I'm going to discuss each of these different spectrums very briefly, but just going through the treatment algorithm for each. So for PLRI with or without a simple dislocation, non-operative management of these is usually unsuccessful, and it has no real clear evidence in the literature for its success, but it can include things like avoiding aggravating activities, physiotherapy, and dynamic bracing with the forearm in pronation. It's essential if you're going to go through to operative management, to repair or reconstruct the lateral ulnar collateral ligament, and that can be done with palmaris longus semitendinosus or even plantaris grafts, as this provides the main restraint to supination of the ulnar and posterolateral forces at the elbow. And if, moving on from this, the CEO or common extensor origin can also be repaired over the top of the lucal, and if the elbow is still unstable, then the MCL should be addressed via a medial approach. O'Driscoll performed a study on this, looking at 44 retrospective cases, of which some had repairs, some had reconstructions, and found better outcomes with reconstructions, and none of their patients had recurrent instability. However, there is literature to say that up to 25% of patients that have the lucal repair or reconstruction have ongoing instability. These are some images of different types of lateral ulnar collateral ligament repairs and reconstructions with transosseous tunnels. So a repair with a Krakauer stitch on the left-hand side of an acute tear, and then a reconstruction on the right-hand side. In terms of post-operative management, it's often a contentious point, but I found a very nice little algorithm for post-op management after lucal repair for these kind of injuries. So initially the elbow is splintered for 7 to 10 days at 90 degrees of flexion, and then a hinged elbow brace is applied after that. And the patient is allowed to do some active assisted range of motion for 6 weeks, but they have to do the flexion extension with the arm in pronation, and can only do pronations going to supination at 90 degrees of flexion, and they shouldn't be doing any lifting. The brace gets unlocked at 6 weeks, and that allows them to do some more flexion extension in neutral and supination, and start strengthening a bit later as well, while the brace comes off anywhere from 8 to 12 weeks depending on the patient's compliance, and then they're usually unrestricted by 4 to 6 months. So it's a pretty significant injury which requires very specific and careful rehabilitation to ensure a good outcome for the patient. The next one is PLRI with a radial head fracture, and so it's documented very widely in the literature that the radial head should never be excised in the setting of dislocation or posterolateral rotatory instability, as this leads to further instability. So if the radial head is fixable, then it should be done with attention to the safe zone of the 90 to 110 degree arc in line with Lister's tubercle and the radial styloid arc. If not, then arthroplasty can be considered. However, there is some literature that's just come out in the last year to say that up to 25% of patients end up having a reoperation, and this is often within the first year, and the majority of these operations are prosthesis removal, while the other 10% is revision of the prosthesis. Moving on to PLRI with coronoid fracture, and this picture describes the main classification systems for the different types of coronoid fractures. To have an isolated fracture is very uncommon, and these are usually due to shear or axial load type forces, as the tip is actually free of attachments, and so these tip fractures that are seen in the Radial type 1s are not actually due to capsular avulsions. It's because there's nothing that attaches there. In the majority of patients, there's a couple of studies that say that it's about 5 to 10% of patients do have a very small capsular attachment to that tip. So there's the O'Driscoll classification, which splits the fractures into tip, anteromedial facet, and then base. And the anteromedial facet is the ones that are seen commonly in varus posteromedial rotatory instability, which we'll talk about later. And then the Radial classification is split based on the size of the fracture, so tip less than 50% and greater than 50%. In terms of management for these, it is controversial. So type 1 tip fractures have historically been left alone, as it's believed to not contribute sufficiently to stability in cadaver studies, and so they don't need to necessarily be fixed. However, if the elbow is still unstable despite addressing the important structures such as the radial head, the lucal, and the MCL, then there is some evidence to say that the tip fractures should be fixed as well. And the larger fractures, the type 2-3 fractures, should almost always be fixed to improve, especially varus stability, and these can be fixed using buttress plates, screws, or even suture lassos. The screws are thought to be biomechanically superior. However, there are some studies that say that the lasso has fewer complications and are more stable intraoperatively on II. However, it is controversial. So these are some pictures just depicting a suture lasso repair and a screw repair on the right-hand side. Moving on to terrible triad injuries, these are almost never managed non-operatively. However, this can be considered in appropriate patients where there's been a concentric reduction of the elbow, the radial head is completely undisplaced or not amenable to fixation or arthroplasty, and the coronoid fracture is small, whereby the patient is able to start early range of motion. However, the majority of these end up having surgical fixation of the radial head or replacement, as well as a lucal repair or reconstruction, and then for larger coronoid fractures, these should be fixed as well. There's some treatment algorithms, which I'll go into in just a second, but essentially if the elbow is still unstable despite addressing the radial head, the lucal, and the coronoid, then the MCL should be repaired as well. There's a good study by Waters in 2014 looking at radial head fixation versus arthroplasty, and they showed that there's actually up to 30% of patients that have instability ongoing postoperatively despite lucal repair and MCL repair if the radial head is only ORIFed. However, if it's replaced, they saw 0% of ongoing instability. However, those that had a replacement had a high degree of osteoarthritis in the future, the subsequent follow-ups. So this is a treatment algorithm whereby the radial head's assessed first and then the coronoid generally after that. And then the patient is put through a hanging arm test whereby there's a bolster placed under the arm and the forearm's allowed to hang with the weight. And then an II shot of the lateral elbow, if that shows any or a non-concentric reduction or it grossly it dislocates again, then it's obviously extremely unstable still and it should move on to a lucal repair. And then if again it shows ongoing instability, then the MCL should be repaired. And then finally at the end of the line, external fixators can be applied if there's still ongoing instability. So moving on to just briefly posteromedial rotatory instability, which is an uncommon and a condition that's been only recently documented in the literature. And this is generally thought to be due to an injury with an axial load and varus force on the elbow with internal rotation or a pronation moment acting at the elbow. The trochlea shifts anteriorly and contacts the anteromedial coronoid, generally causing a fracture of that, and you don't see that typical posterior or posterolateral displacement of the radial head. So generally, this is split into two stages, whereby stage 1 involves a coronoid fracture and stage 2 includes a lateral collateral ligament disruption, and there's usually a posterior bundle MCL tear as well in these circumstances. This is another video showing the mechanism for posteromedial rotatory instability. So you can see the coronoid hitting the trochlea there, causing that fracture. So this is some imaging showing the stage 1 in the top right with a coronoid fracture without lateral subluxation, and then a stage 2 in the bottom right where you can see that the radiocapitellar joint is widened on the CT scan. In terms of how patients present, usually the clinical signs are non-specific. However, they may have an ulnar nerve neopraxia, and the stress tests are not as good for this condition at picking it up, especially in the clinic, and often require EUA. The hyperpronation test is a test done with the elbow at 90 degrees flexion and then passively hyperpronating the forearm while palpating for any ulnar humeral subluxation, while the gravity-assisted varus test is done with the shoulder abducted, the forearm in neutral, and then the elbow is moved from extension to flexion, and looking for instability, pain, and crepitus with just gravity acting on the shoulder and providing a varus moment on the shoulder. On the elbow. And this is an MRI depicting a characteristic lesion for the posteromedial rotatory instability. So the yellow arrow is pointing to the common extensor origin, which is completely torn in this circumstance. The green arrow is pointing to the radial collateral ligament, which has been torn, and then the orange arrow is the lateral ulnar collateral ligament. And you can see how on these images it requires a very specialized musculoskeletal radiologist to be able to call these, and this is why MRIs can sometimes over-call injuries at the elbow, because this is pretty subtle findings, and I guess it's also due to the picture being slightly blurry. However, the red arrow is pointing to an obvious anteromedial facet coronoid fracture, which is the typical lesion. Just briefly, and coming to the end, this is just a couple of points about chronic unreduced dislocation, whereby the elbow has been dislocated for more than 3 weeks. It's often seen in third world countries with poor access to medical care. The treatment in this circumstance is open reduction, excising the capsule or scar that's formed due to the dislocation, and then a lateral ulnar collateral reconstruction. And most patients will need a dynamic hinged external fixator as well to hold the elbow reduced. And so that's seen in this picture here, to allow for a concentric reduction to be maintained.